Let me introduce the next speaker, Dr. Michael Campbell. He is the visiting assistant professor of philosophy and our center. I think he was graduated from in philosophy in Cambridge, right?
Yeah.
Okay. And so before he coming to Hong Kong, he was a research fellow in philosophy at Kyoto University, and his research interests are intersection between meta ethics and applied ethics, particularly personal identity and human enhancement and nature. So today he's going to give a talk about the fiduciary concept. Can it be extended to include the wild healthcare community? So let's welcome Dr. Campbell.
Thank you all very much. First of all, I'm going to apologize for my voice. I've got a bit of a cold at the moment, so I sound a little bit gravelly. Maybe it adds a bit of authority or gravitas. Possibly, I'm not sure. It's a terrible, terrible, terrible thing to have to give a talk after Professor Kumta, because he's always so interesting and informative. And what I'm going to give you today might be informative, but it's definitely not going to be interesting. I'm going to give you a slice of pure philosophy. So I hope you're all ready for that. Okay. All right. So what is a fiduciary duty? Well, the word fiduciary comes from the Latin fiducia, which is, of course, cognate with the English words of fidelity and faithfulness, and is related to the notion of trust. A fiduciary duty is really one half of a trusting relationship. When a patient entrusts themselves to a doctor, then corresponding to that, from the doctor's point of view, the doctor assumes a fiduciary duty with regard to that patient. And what that duty essentially comes down to is the requirement that whenever the doctor acts in a way that affects their patient, they have to act in that patient's best interests. Right. Now, there are two ways in which you can violate a fiduciary duty. One is to act in a way which is obviously contrary to your patient's interests. For example, a doctor might prescribe a treatment knowing that it's not the best treatment available, but doing so on the grounds that they're getting some money or some financial inducements to do so. The second way in which you can violate a fiduciary duty is a little bit more subtle. You can violate your fiduciary duty if you act in a way which is only contingently or accidentally consistent with your patient's best interests. So, for example, a doctor might prescribe a treatment because they're receiving pressure or financial inducement to prescribe this particular medicine or this particular treatment. And it might just happen that in this case, that treatment is the best one available to the patient. But the doctor's motivations in prescribing it weren't their judgment that it's the best, all things considered. Their motivations were the money, or at least in part the money or the incentives or the benefits that they themselves were gaining from it. So in that case, in the second case, the doctor essentially gets lucky. It just so happens that the patient's needs and their own self-interest are dovetailing. What the second case tells us is that the fiduciary duty isn't just a requirement that you make sure that things turn out okay for your patients. It's a duty that you make sure that when you're treating your patients, you're attuned to their needs. It's a motivational requirement on doctors that they be sensitive to the patient in front of them and that they block out any external influences, such as financial gain or self-interest, which might press on and influence their decision-making. So in that way, the fiduciary duty is actually really strong. It's a requirement that you attend properly to the needs of the patient in front of you and don't get distracted by requirements of what you personally need or want. Good. So if that, in a nutshell, is what the fiduciary duty is, then one question we might ask is, how are we going to relate it to the other principles of healthcare ethics? Now, Professor Kumta, in his talk, already very elegantly explained whenever we discuss principles in healthcare ethics, our natural starting point is Beecham and Childress's 4 principles: respect for patient autonomy, beneficence, non-maleficence, and justice. I think it's a little bit unclear precisely how we're going to derive the fiduciary duty from these 4 principles, but something like a combination of respect for your patient's autonomy and beneficence, always acting in their best interests, some combination of those will probably yield a fiduciary duty. And if that's true, then we can represent the fiduciary duty as being derived from the fundamental principles that are supposed to govern the behaviors of doctors. Good. Now, what I want to talk about today is not really anything to do with the precise details of the framework. I want to raise a criticism of this way of looking at things. So a kind of criticism, if you will, of the fiduciary duty or talk of fiduciary duties. My criticism isn't going to be internal to the picture, but rather external to it. I'm interested not in what it says, but in what it fails to say. And I'm going to suggest that there are a whole host of background conditions or background context which have to be filled in or met in order for us to meaningfully speak of the fulfillment of a fiduciary duty. So I'm going to suggest that what focus on these 4 principles does, at least sometimes, is distract us from considering this really important background context. And that's a context that shouldn't be ignored. Okay, so that really actually brings me to the title of my talk, which, if you'll remember from the first slide, which you probably won't because it was only up for a second, but the title of my talk is Trust in the System. And that's actually ambiguous, deliberately ambiguous. Some might say clever. I wouldn't say clever, but okay. It's ambiguous because trust in healthcare is something that occurs between 2 individuals who are working within a system. So trust is something that occurs in a system. One trusts one's doctor not because you know them, but because they're a doctor, but because they're fulfilling their professional responsibilities. And that means whoever's wearing the coat and has the stethoscope is someone who people on the street with very little education immediately feel they can trust. And that trust is earned, why? Because they know that that person works in a system which is set up in such a way as to be responsive to their needs. Good. But what follows from this, I think, is that if we're going to have trust between 2 individuals, we also have to have trust in the system as a whole. So one way in which you can undermine an ethically sound doctor-patient relationship is by having an unethical doctor. But another way in which that relationship can be undermined is to have an ethically good doctor in an ethically bad system. If we're going to have trust between 2 people, we have to be able to have trust in the system as a whole. Okay, good. So in much of talk on medical ethics in terms of fiduciary duties, and this was possibly implicit in Professor Kumta's talk as well, there's an assumption that the doctor-patient relationship is a relationship between one patient and one doctor. And that's obviously, and this is going to be very familiar to all of you, a simplification of the pathways to healthcare, which are in fact really complicated. Even in the most straightforward interaction, a patient is going to come into contact with primary care physician, possibly an ambulance technician, certainly a receptionist, an orderly, physical therapists, specialists, surgeons, and so on and so on. And all of these people are going to interact both with each other and with the patient. And so the sum total of these interactions, it's the sum total of them that constitutes the care that the patient receives. And the care that the patient receives is going to have a significant, although not definitive, effect on that patient's health outcomes. So if we're going to have adequate care, what we need is to have this system, this network, set up in such a way that it efficiently ministers to the needs of the particular patients who pass through it. Now, suppose we have a system which is arranged in such a way that patients fall through the cracks. And Professor Kumter described some examples of this really nicely when he was talking about the banality of medicine, with the patient who has passed from one person to another and said, you have a 2-year waiting list, and then another 2-year waiting list, and so on and so forth. We're then going to have a system, or a situation rather, where when a patient goes to see a doctor, they know that the doctor is going to refer them on, and that they're going to start to pass through this really labyrinthine system, which isn't tailored in a way that's going to efficiently meet their needs. If that's the case, then a patient can well turn around and say, I know that my doctor here is a really great guy, and I know that he's trying to act in my interests, and not in his own interests, but the system is set up in such a way that it doesn't matter. I'm not going to get the treatment that I need. And in that case, although the fiduciary duty hasn't been violated, it's become meaningless. It's hollowed out. And why is it hollowed out? Because the background context hasn't been properly set up. Right. So there are 2 points, I think, that deserve special emphasis here. The first is just to repeat what I've said. If our healthcare system isn't set up in a way to be responsive to patient need, then fulfilling one's fiduciary duty is no longer going to be sufficient for ensuring that one's acting in the best interests of one's patient. We need more than just goodwill on the part of individual physicians. The second point is a little bit more controversial. If we want to ensure that healthcare is being optimally provided to meet patient need, I don't think we necessarily need to extend the fiduciary duty so that it applies to every party involved in healthcare provision. So in this list, or in this sort of diagram, we have medical personnel on the right-hand side, and that is going to include, right up at the top is going to be someone like a clinical researcher or maybe someone who works in the pharmaceutical industry, and then we're going to have specialists and clinicians and primary care physicians and ambulance technicians and so on and so forth. One way in which we might try and ensure that our system is set up well is to say every time there's an arrow from patient to personnel, we ought to have a corresponding fiduciary duty. So every time someone's behavior affects the patient, they ought to be acting only in that particular patient's best interests. But I don't think we need to ensure that our healthcare system is set up in that way. I don't think these arrows have to represent fiduciary duties. Part of the reason for suggesting that is that this list of people is almost endless. And another reason is that it's just going to become a cat's cradle of responsibilities, a huge tangle, if we think that in each case we have to have a fiduciary duty linking personnel and patient. I think instead we can hold that the fiduciary duty really applies to a patient and a doctor, but we have to ensure that doctors are working within a system and that that system is tailored in such a way that it's optimally responsive to patient need. And that's going to involve clearly delineating different roles for different individuals within the network, different professional roles. Okay, good. Well, so having made this point, I seem to have opened up just a huge number of problems. Because we now have to say, well, that's all well and good, Michael, no one's going to disagree, but what constitutes an appropriately arranged healthcare system? So what kind of context is necessary for the fiduciary duty to have any actual content? I'm going to say two things about this. The first thing I'm going to say is that provision of healthcare is a matter of justice. And that applies, I think, however richly or austerely you understand justice. The most minimal conception of justice that I can think of is that a just society is one that ensures that each individual has an equal opportunity to leverage their talents. So a just society is one in which each of us is given a chance to do the best with whatever skills genetic inheritance has given us, our genetic inheritance has given us. Well, if that's how you understand justice, and that's a really minimal conception, but if that's how you understand justice, then healthcare is absolutely fundamental to justice. That's because ill health isn't under our control, at least not generally, and it deprives us of the ability to make the best of our lives that we can. It deprives us of opportunity. If I'm suffering for pain or infirmity, or if I'm one of the afflicted patients who has a horrible tumor or whatever the case may be, I can hardly be expected to compete on a level footing with people who have perfect health. And so it follows from this, I think, that in order to secure equality of opportunity, we have to secure equality of healthcare provision. And so that means, I think, that a just healthcare system requires that provision be receptive to need and not to benefits which might have accrued to an individual through their own wherewithal or even through good fortune. Now, obviously, this raises another huge question, which I have an opinion on, but I'm not going to discuss, but which possibly CUHK, Professor Kumta touched on again in his lecture, which is what happens if we introduce a profit motive into a healthcare system. Does the introduction of private enterprise into systems of healthcare make the system more efficient at responding to patient need or less efficient? Does it make it more just, more equitable, or less just? I'm just going to raise that issue and let you think about it and not give you my own opinion. Okay. So suppose then that we have a healthcare system in place where each of the participants here stands in a network of professional duties, arranged so that in the absence of things going wrong, in the absence of a system failure, patients are going to pass through their care pathways in the optimal way relative to the conjunction of their particular needs and the overall demands on the system. How then ought we understand the physician's fiduciary duty in this case? I realize that all of my points dovetail really nicely with Professor Kumta's, and I think the reason for that is that Professor Kumta's his presentations are always so clear and helpful. I'm not even sure why I'm up here. So my talk boils down to, what he said. Good, okay. So how ought we understand the fiduciary duty? Well, here's one way you could understand it. The physician's duty is to ensure that their patient gets the best treatment possible by advocating to the best of their ability for their patient's interests as that patient passes through the system. This more or less mirrors the understanding of the fiduciary duty as it applies in legal and financial contexts. The role of the doctor then would be as a kind of advocate for the patient's interests. And at least part of their job would be to game the system, without, of course, overstepping legal bounds, in order to promote the best possible outcome for their particular patient. So in September, some of you may have been at another of the clinical ethics workshops, the one on the duty of disclosure. There was a talk given by Dr. Colin Graham, who's a professor of emergency medicine in Hong Kong. And he was discussing the role of artifice in the provision of healthcare. And he described his job as basically involving exactly this, gaming the system. He talked about cases where you would say to a radiologist, my patient has a diffuse pain on one side of their body, or something to that effect, in order to ensure that they got the scan that they needed more quickly. Even when you know that they don't have this pain, or if they did, you can tell in your clinical judgment it isn't likely to be indicative of a serious problem. But still, you go into bat for your patient, so you game the system in whatever way you can. I'm going to suggest that in a well-ordered system, we don't have to do this. And the fact that Dr. Graham, Professor Graham, thinks that he has to do this indicates that there are systemic failings in the system in which he's working. And I think he'd probably agree with that. In a decent healthcare system, the fiduciary duty shouldn't require doctors to view their job as gaming systems in their patient's advantage. And the reason for that, I think, is this. Healthcare is a finite good. Okay, there's no upper limit to the amount that we can, in principle, provide, but the demands of health always outstrip our capacity to provide it. We can see that really clearly if you take the World Health Organization's definition of health, which is really capacious, really broad, right? Health is a complete state of mental, physical, and social well-being. Now, given human nature, and given that definition of health, it's obvious we're never going to achieve perfect health for everyone all the time. Even if we somehow got rid of communicable diseases, there would still be the illnesses related to aging. Even if we got rid of the illnesses related to aging, people are still going to go skiing, and they're going to break legs, and they're going to engage in all kinds of self-harming behaviors. So I think no matter how hard we try, we're never going to exist in a world in which healthcare is plentiful. It's always going to be scarce. It's always going to be a limited resource. So given that fact, there's always going to be competition for healthcare resources between individuals. Not everyone is going to get optimal or even adequate treatment all of the time. And the problem with doctors seeing themselves as patient advocates is not so much what it will do for their patient, but what it's going to do for other patients within the system as a whole. Because in Professor Graham's case of the person gaming the system, if my patient is getting the scan, then there's another patient who isn't, or isn't getting it right now, or is having to wait. And the person who misses out may have equal or even greater claim to treatment. So what doctors have to recognize, I think, is that although there's a very strong temptation to play an advocacy role and to game the system on behalf of patients, their patient is only one amongst many. The broader goal of medicine has to be not just meeting this patient's needs, but meeting the needs of all patients to the greatest extent and in the most equitable way possible. And this, I think, brings us back to the connection between healthcare and justice, and really the fundamental nature of healthcare. I think healthcare starts and really finishes with the insight that those who suffer equally, that each is equally entitled to treatment, and that treatment should be based on need, not on extraneous considerations like who has the most charismatic doctor or who has the most amount of cash. Thank you very much. Thank you.
Thank you, Michael Campbell. It was quite interesting. Great talks about the justice and justification in the spectrum of the individual doctor and system.